Um, okay. I will not click the option that says leave meeting. So we can, I'm sure somebody's done that accidentally in the past. But what I'd love to do is offer both Avinash, if I can call you that, Dr.
Yes, please.
Abinar, and Camille and Marianne, who I know from prior work life at NICHQ. If I could ask you each to, or the two organizations, just to spend a few minutes giving an overview of how you all think about the intersection between health and healthcare, including what you're thinking about or what you think are common goals and priorities and what opportunities are to work together. Just for a few minutes, like 3 or 4 minutes, and then I have questions and I want to dig into some conversation with you.
Great. May I go first?
Yes.
Yes, you're alphabetically both on both accounts.
I'm always first. When I was always
say.
called on first. I was always picked first. Yes, thank you. So my name's Avinash, and I really wanted just to take 30 seconds to say why this is so important. The emergency declaration is now over. So what are the good things that came out of this, just 3 years of kind of chaos? And in my mind, the things that really we benefit from now today is even the fact that we're having this discussion. The fact that equity has been brought to the forefront, and public health, which has been mired in the dirt, poorly funded for so long, and no one knew that public health was even existing, is now in the forefront. You can walk to any grocery store and ask somebody about epidemiology or viruses or good hygiene, and people will be able to say something intelligibly to you. It may not be all right, but at least they have that common jargon and the words in their brain to communicate how they feel about public health. And I think the vast majority of Americans had no idea that there was health equity issues. It exposed what we already knew in this community already, that social determinants of health are real and they need to be addressed. So briefly, what Wellness Equity Alliance has done, you heard my bio a little bit. I have spent my time mostly in the public sector. I'm still a professor of medicine at a large university, but I also was the state health official in New Mexico with this current governor up until the end of 2019. And what I found, and the most frustrating thing about public health, this was right pre-pandemic, is we had some dollars available, not enough, but we had no partners in the community to do the real work that we wanted to do. So the Department of Health was tasked to scaling up or scaling down or moving FTE to certain locations, and we couldn't do it quickly enough in a government organization. So many of us state health officials got together and started a company to address that very issue. And we can talk about that as we go along, but that was the impetus. The impetus was to be more malleable, to be more aggressive when addressing certain problems in the community, to be able to ramp up and ramp down where health departments just didn't have the chops, or they didn't have the structure in which they could do it.
Great. Thank you, Avinash. Over to IHI.
Thanks, Lauren. I'll kick us off. I'm Marianne McPherson, and it's really a pleasure. I've been IHI's rep to the Alliance, I think, since we started out, and I've really valued so much the conversations that we've had here, and I'm just delighted to be in this seat today. So thanks, Angie, for the invitation to do that. I think by way of my piece, and then I'll hand over to Camille. I joined IHI in 2015 after Lauren and I worked together, which was a tremendous privilege to join for an initiative called 100 Million Healthier Lives. And that really proved to be, an incredible set of work in a lot of ways. We worked IHI convened this initiative that ran for about 6 years. We worked with partners in 30 countries and reached more than 500 million people and learned deeply lessons about partnership across sectors, what it means to center health, well-being, and equity. And the lessons from that work have continued to be really profound and meaningful over the last 3 years amid the pandemic. So I thought I might just start by naming some of those in terms of some of the lessons we've been learning, and then hand the baton over to Camille for some of how that's coming to life in areas of our work now. And I mentioned that it was a broad-based network of partners. Many of you in the room, hi. It's really nice to continue to be in space together. And we were working not only in healthcare and public health, but across housing and community development, and addressing a host of topics, people from community leadership, state, local, tribal leadership, national leadership, again, in 30 countries, on a whole host of topics, and figuring out together kind of what it meant, how might we work together so that a particular community or jurisdiction could identify what mattered to them and work their way forward no matter what was the challenge they were facing, in a way that centered in a meaningful way health, well-being, and equity. And so some of what we learned included, what did it mean to work in relationship in a broader and deeper way? It was essential to be engaged in deep co-design with the people whose lives were and are most affected by that work. Recognizing, like, yes, coming with ideas is great, but we used a metaphor of puzzle pieces a lot, and suggesting that we all hold a piece of the puzzle, but the only way we move forward together is to be willing to come around a table together, put our own puzzle piece down, and see what the picture looks like. So know we come with something, but be very willing to let that go and have it be shaped by those with whom we're in partnership. Because if we don't do that, we're going to live in a land of projectness and never get aligned around what it means to sustain work in a meaningful way that matters over the long term. We also learned to think about leadership in broader and deeper ways, and recognizing that some of what's required is very individual, understanding what each of us needs, having the ability to be self-reflective and humble as leaders, and what it means for individuals to sustain the work, what it means to be in true, authentic relationship and partnership interpersonally with one another. What are the then tools and methods that allow us to lead and achieve meaningful outcomes? To think of sustainability in a broader frame than just money on a specific project, and to do all of those things in a way that from the start and all the way through centers equity. And part of what that meant for us too was, like, asking questions that matter. So we would anchor on questions that have continued to be relevant, like, whose lives are getting better because we are here doing this work? Who is not thriving? And what will it take to change that in partnership? And then really being intentional about naming health, well-being, and equity together. Naming what are the dimensions of each of those concepts? What does it take to measure them in a way that is meaningful, and to not disconnect them from one another, because they're interconnected in how we live as individuals and communities and our institutions, and often they get connected. And those lessons really carried forward into the continuing pandemic as partners have worked out how to continue to move forward. So we know that it's exposed these deep and long-standing cracks and inequities in our systems, and having some of these lessons and ways of working to fall back on have proved really important. So let me pause there, and Camille, invite you in.
Great, great. And so Camille, please jump in and say a few words. And then like I said, I really want to get into some dialogue.
Okay, that's fabulous. And thank you. I think this has been set up so nicely by my colleague Marianne, as well as my co-presenters here. And just thank you everyone for the opportunity to really bring this to the forefront. And I think building on what Marianne had spoken about is really been the journey of the organization IHI has been on in this work. And as was mentioned, earlier, that we know that equity work has really come to light around COVID and the multiple pandemics is what I like to say, around social unrest and racial justice, which are really centered in the work that we're doing moving forward, that has been built on the history of the work that Marian just talked about in partnership. And so on that thread, I think the space that we are in now is really looking at galvanizing all of what we know about equity and justice work towards creating a broader, more interconnected ecosystem of everyone working toward a shared goal, a common destiny. And we know the thread that unites all of us, whether it's public health, health organizations, et cetera, is equity and justice. That is the common denominator. And it transcends these, what I like to say, artificial lines of health and what that health is. And so IHI does a lot of work with a lot of key stakeholders within healthcare. Many of them have a responsibility as an anchor institution, especially if you're a healthcare organization and you're probably the major employer in the community. You do have a responsibility in that space. And so really thinking about the role that anchor institutions at large play, and recognizing that part of that role is really to not just do no harm, but also to do good. And what does that mean? And really diving into exploring the history of our organizations together in a meaningful and intentional way, through very specific opportunities that IHI sort of leverages to help guide people on a journey, is what we call it, an equity journey. And so part of that is also thinking about that responsibility more broadly, and what does that look like, and how does that impact the broader determinants in the communities that we have the privilege of serving. And so Marianne did allude to some of the opportunities that come from recognizing this sort of interdependence that exists, and that we know that within the healthcare sector and as well within public health, that we all need each other. And COVID was a very prime example for the need for this, and why that was important. And that addressing drivers of health belongs to all entities that are engaged in this health work. And we need to have this sort of wraparound approach to individuals and families and communities. And at different ends of the spectrum of health, is happening in different ways. And so what can we do collectively to kind of galvanize all of these efforts that are happening? And unfortunately, in many cases, very siloed and very patchwork approaches. And so at IHI, we've been looking at pulling all of that knowledge together and bringing people into community in different ways. And so we have different action networks where we bring organizations together to do some really deep work around making meaningful, impactful change. We also have a Chief Health Equity Officer program that will be launching in the fall. And we look at really what are some of the roles and responsibilities and competencies around that. But the bigger space that we're really joining in now is really coalescing around a national coalition, which we're calling the Rise to Health Coalition. And the coalition is really bringing together these key system actors, starting with predominantly around health organizations, pharmaceutical, biotech, and research entities, health plans, professional societies, individual practitioners, around a shared mission and a goal to advance equity through action. And we want to do that so we can build capacity, expand knowledge, mobilize what's already known, and really start to make some real coordinated change in an ecosystem across key impact areas of access, workforce, the social structural, the drivers of health, and as well as quality and safety. And so those present ways in which we can start to think about, how do we sort of move forward with this recognition that even though, our CEO, Dr. Mate, had just recently said in a recent political article that even though the public health emergency is ending, COVID is not, and our systems need to start thinking about how do we respond in a more equitable way. And so this really just leads us to start, really having the space, the bandwidth, the ecosystem by which we can continue to move this work forward and not feel like, okay, there's this pause, there's this window that's now closing. In fact, setting up the infrastructure to really create a transformative healthcare ecosystem for everyone to thrive.
Well, thank you. You've given a lot. You clearly have a lot to share and a lot to to dig into. So I'd love to step back from that very good overview of where some of the opportunities are now, and step back to perhaps a more foundational question around that's, I think, perhaps a reason why sometimes this work at the interface between public health and healthcare has been relatively fraught. Speaking from my own experience as you know, a clinician and former public health official, I'm wondering if you all could dive in a bit to, and maybe this is, you know, a little bit, but we're, you know, this is Vegas, right? We're all among friends, and I figure we have to address these tensions. There's this potential or fundamental tension around where the focus is along the prevention continuum, where you know, when you're in public health, you're thinking very much around primary prevention, maybe some into secondary prevention, but definitely around primary prevention. And even more, as we've gone, and each of you in your own way have alluded to, what are the systemic and structural changes that we can do to make communities healthier so that people don't get sick in the first place? So there's this increasing focus on primary prevention and the social determinant or social or structural determinants of health, however you want to talk about them, or some people call them the vital community conditions, you know, those things people need to be healthy, which are systematically not available to many populations, all the way through secondary prevention and into tertiary prevention, if you will. Once you get sick, making sure that you get what you need and you don't suffer consequences. So I'd love, and I have found that tension around what is our chief goal, what is the North Star, can be a source of friction between public health and healthcare, with some saying, well, gee, we don't really, you know, healthcare means that we failed in public health in a way, right? The fact that people need healthcare, because if we were really great at primary prevention, we wouldn't have people developing obesity and heart disease and cancer at the rate that they do. Versus others said, no, we must have healthcare because there's always going to be people who, you know, get downstream. So can you talk a little bit about that? Because I feel like, you know, in our family meeting, we need to address that there's that tension there.
I can go.
You know what I mean, though. I'm seeing you nod.
I do, because you know, as a cardiologist, we talk about prevention all the time. Mostly what I do is secondary prevention, but primary prevention is key. But I think the term we should really be using in public health is primordial prevention. That's what we're really talking about, because we can prevent even disease that we know might be coming. For example, if you have gestational hypertension, your child is at a higher risk for developing hypertension themselves. That's before they're even born. We know that there's data. So that's like primordial way to look at it. I think probably the intersection, the confusion and the tension is something that it was the impetus of creating this company. And I could clear this with Angie just to bring everybody on board. If I could take like 3 minutes just to kind of, I had a little slide deck, if that's okay. I don't want to disrupt the process though.
Well, let me ask, before you go into your slides, I would love to give Camille or Marianne an opportunity to answer what I was hoping would be a fairly provocative question.
Well, provocative it is, and I'm so glad you asked that question, because I feel like that is such, you know, people like to say that's the elephant in the room, right? And it really truly is. And so in my mind, I see that tension stems from just the basics of understanding or agreeing to what health even means and what the fundamental definition of health is. On one spectrum, you have a resource for everyday living, and another spectrum, you have the absence of disease. But I think we really need to come beyond that bifurcation and say, listen, health happens everywhere. It happens everywhere. It happens, yes, across a continuum. And because of that, there's different spaces for health. And we're not brokers of this health. We don't hold this holy grail of health and we broker it out to people from our different spaces. In fact, if we start to think about it in a more sort of liberation mindset and say, we're building on assets and people are the experts of their health and we co-create this together, then it kind of takes away that, well, I own this section and this sort of actor or entity owns this other section. In fact, we all have an opportunity to be a part of the health solution and thinking about health more broadly in a more encompassing and all-encompassing way. And so this is something that's very near and dear to my heart, and I'm so glad that you asked that question. I'll just pause a little bit and give Marianne or anyone else the opportunity to weigh in. But I do think it starts from that. It starts about having that commonality of understanding. But when we're talking about it, what exactly does that mean? And there's a difference even across public health and healthcare organizations and the health system, even across practitioners. It's different as well. So I'll pause there.
I would add in this moment that, you know, you named, Camille, one of the things that's underneath the surface that holds us back. And I think that sometimes also what holds us back in a provocative question, in a provocative moment, is not naming what are the other structures, systems, policies, ways of working, power dynamics, money flows, that as we are people who generally go into public health and healthcare for good reason, we get into systems and structures that restrict us in certain ways, or that have us within power structures that are themselves oftentimes inequitable and constrain. And there is history of harm, and there is sometimes current experience of harm. And so how might we really explicitly name those things? Because when we don't name them, it's not like they're not there. The elephants in the room just kind of grow bigger and take up more space. And so I think the ability to create the safe and brave spaces for collaboration that allow us to name the things that have held us back, that have created harm, that might be barriers in this moment. Sometimes they're really big things, and sometimes they're littler things, like we're using the same word to mean different things, or we're using different words to mean the same thing. But if we're not able to slow down and name those things and have the conversations about what will it take to enable us to move forward, then they will just keep getting in our way and slowing us down.
Great. I appreciate that. Thank you. Thank you. Thank you for that. And so back over to you, Abhinash, if you could pick maybe just one or two slides for a couple minutes, because I do want to be
Yeah. Let me
have
just
more of a
share.
conversation than
Well,
slide.
you know what? I don't even need to share slides then. That's totally fine. That's totally fine. We could just continue. I just wanted to get the understanding, as somebody that's been in public health and in the public sector for so long, the idea of how the private sector is now intersecting with the public sector, I think is very important. Speaking as a former state health official, there's dollars now flowing into the areas that we are talking about. This is beyond the HMOs, beyond the Medicaid plans wanting to work on population health. They have their reasons. And now we can build for those reasons. I'm still a clinician. I still see cardiac patients. I still see general medicine patients too. But beyond population health for those metrics, I think we're seeing dollars flow into these areas where we are understanding their work needs to be done. The question is, does the public health footprint, the workforce, can we step up to meet the demand of the work that's necessary? And we might, but I can tell you currently in the state of New Mexico, we couldn't. And I know one of my former colleagues is here from New Mexico, that we couldn't find extramural partners or vendors or private sector entities that could help with the work properly in the way that we needed. And I think that understanding is we're probably going to see more companies such as ours entering the sector, because there's nothing wrong with public health getting help from the private sector. That's how healthcare formed. It started as a public endeavor, and now there's many, maybe a majority in some states of the private sector working in healthcare. And there's nothing wrong with that. There's almost, when I was talking about this early on, I would say about a year ago, it was almost like sacrilege. Like, how can you conceivably do a project and think about a profit margin and think about public health at the same time? And I think we need to get beyond the fact that we pay our public health nurses the lowest among nursing levels, and that we are wondering why there's not a workforce available when they've been trying to deliver with an unfunded mandate for so long. So that's how I feel. And so I don't need to share slides. I just wanted to make sure that we're understanding that there's now the private sector interested and willing and well qualified to help address some of these problems.
Well, I think that that's actually a good segue to the next question. And I'm looking at our time, knowing that, Andrew, you can chat me how much time you want to leave at the end, so I know how much time we have left to talk. You all, in your own ways, each of you mentioned the concept of relationship, and several of you, or actually all three of you, put some qualifications around relationship. What's authentic? What's real and meaningful? What's not transactional? Those kinds of elements. So I heard that. I'm wondering if you could dive into, again, one of these friction points where when healthcare systems are looking to work, especially with city or governmental public health, say, just sticking with governmental public health, there's a really significant difference in power. Avinash, you were talking about resource flows and just mass of total scale of resources that are available. So I'm wondering if you could talk a little bit about how to approach functioning, effective relationship between entities where there's this intrinsic power and resource differential. You know what I see, again, seeing nodding. I'm just checking. I'm getting used to these new glasses. They're progressives, and I have to make sure I'm interpreting your facial expressions correctly. So who wants to go? Camille, or Marianne, you want to go first this time?
Sure, I'll start. As I think the only person in this group who has worked neither as a clinician nor in governmental public health, so I'll just go on that. But actually,
I never stopped anyone from having opinions.
So here I go, right? The first thing I was going to say is there are very real power differentials between institutions, Lauren, as you named, and institutions are composed of people. And so I guess part of what I was mentioning before about beginning to name the things that hold us back institutionally, I think that's relevant here too, as well as opportunities to be bringing our human selves to the work as we're building relationships across our institutions in a way that that owns and doesn't try to gloss over those very real features of the seats that we're sitting in on the institutional buses that we're driving or riding in, but that also allows us to understand that if we don't build those interpersonal human connected relationships, the power of our institutions will be the thing that takes us over. And if we are able, this was a powerful 100 million healthier lives lesson, that if we are able to center relationship building as humans, an honest accounting of what it takes for each of us to be working and leading in this space. What do we need to have acknowledged? What do we need to say? What does humility look like? That can be a way to open up some creative possibilities that help us work within the institutional power structures and constraints where we find ourselves, allow us to work in ways that might not have been apparent before. So I'll start with that and invite Avinash and Camille to improve upon it.
Mm-hmm.
Yeah, great. I think you've set that up beautifully to think about the work more so internally. It's like I have to say, and externally, right? So there's the individual work that needs to be done to be able to show up in ways that are not harmful. We're able to do good and share power and really understand what that means by sharing power. A lot of people speak about that. A lot of organizations say, yeah, we want to share power. And then when it actually is rolled out, it's not even close to truly sharing power. It's very extractive. It's very parachuting in, parachuting out, and it's not bi-directional. And so I think getting honest internally about what that means and what that looks like. And then externally, in terms of acknowledging sort of some of the harms in the history of the institution, we have to get grounded here in truth and speaking truth externally and internally. And oftentimes, part of that speaking truth is saying, listen, we recognize that our organization has this sort of historical lens that we're showing up with. We have a history within the context of that community. And we have a history within the context of the community and within this country and what that is. And so taking the steps to be very intentional actually helps to get to the end result of being able to truly, authentically share power. Because once you start to open up that truth telling, and then you start to redress it in an authentic way, there's no way you can start to that act of redressing it without starting to truly share power. There's ways in this where this has been done very tangibly. I have been fortunate to be a part of institutions, more so on the academic end, but however, they're usually connected to, healthcare medical centers within academic institutions. Of really thinking about how do we start to do that? What does that look like? And so part of it was, preparing properly, really, to do community engagement in a way that is not harmful, that does do good. And then looking at some of the policies and structures and systems that we talked about earlier, setting them up to really make sure that they're also aligned with what we say we want to do and what we actually want to do. So I think there's a way of doing, being, and knowing that all has to be in alignment for us to start dealing truly with that power.
Lauren, could I comment on that?
Yes, please. I was going right to you.
I think, this panel is about the intersection of healthcare and public health. And in my mind, I continue to wear both hats. I think when I'm wearing my healthcare hat, I'm doing stuff. I'm really actively, physically either operating, I'm putting a medicine in somebody's mouth, I'm literally doing something. And on the public health side, I'm more in the planning and project stages. I think that's where that difference is. I think, Marianne, you said sometimes people are stuck in projectness. And I think that part is the problem, that our perception is public health is planning and organizing, but never truly delivery. And healthcare is unfortunately mostly delivery. It shouldn't be, but it is. And I think that we're coming at the same problem from vastly different schemas of belief models, of professional learning models. And I think till we break down that barrier, that public health can be operational, like truly operational, and healthcare can be project oriented and building, that's where this needs to kind of fall away. And that's what I've seen a lot. And I feel my hat changes. And some of my people on my team are like, oh, you're still wearing your cardiology hat right now. That's not how we're going to do this. And it happens vice versa. So I wonder what the rest of the group, even the rest of the people on the Zoom, think about that, because I think it might be a fundamental difference in our background professional training that needs to be worked on to address that issue.
I totally agree. And I think that was sort of the genesis for my first question about like how we're thinking, along that spectrum of prevention, because that does how you enter into the space in terms of what your conception or framing of what the problem is, definitely has bigger impact. I want to leave some time for the folks on the call to sort of weigh in, and I'm going to ask Angie to curate questions. So if people want to start chatting in questions that they might like to add or ask rather, let's do like just a rapid, round where, one, 60-second sort of answers, which I know is hard. And this is a very tactical question, alluding to the ending of the public health emergency. So we know that's ending in May. What are and you know that you're talking to a group of multi-sector collaborators who are, you know, really focused around promoting community health and well-being. What are one or two issues that you want to highlight that you feel this group in particular should understand that might be at that intersection of public health and healthcare related to the end of the pandemic? So rapid fire, quick sort of answers. I'm sure you all are thinking about this because it's looming. Who wants to go?
I'll start. My quick take is, as Camille said, as Kate Armante has said, the public health emergency is ending, the pandemic isn't, and it's not going to be the last one either. And so how might we focus on what are we learning on this? What have we learned so far? And what does it mean to be preparing together so that the things that caught us off guard during COVID don't catch us off guard again when the next thing hits, because it's going to, and because there are predictable things that we could and should have learned. What does that look like for our data systems, our people systems, and how we work together with our communities?
Okay.
I was going to say we have to rethink what it means to be sick in the hospital. Hospitals already function almost at no profit if they're lucky. And any slight disruption of that causes just complete chaos. There's very little play in the system to deal with an onslaught of any particular new disease, and we need to think about that. And I think, you know, the hospital associations across the country are thinking about that now.
Great, Avinash. Camille, anything you want to add?
Yeah, I think echoing +1 to both of you, and I also think how we prepare people in moving forward in terms of, I mean, I love the point that Avinash made, and I think it gets back to sort of us getting aligned together in a North Star. I saw how quickly we were able to align different parties very quickly, and I think that we know that we can do that. We've proven that we can do that. And so I think alignment is really important around how we define health. As I said earlier, alignment around how we practice this preparation in silos cannot happen. How we do research together in terms of transdisciplinary work, how we engage with communities on the front end and build that trust was critical in period of uptake in terms of vaccination, all of those things. So I think some of the background work that was either termed invisible or optional can no longer be optional. It has to be a primary part of our practice. And we have to look at that antiquated practice model that we have and what needs to be changed. I know oftentimes we think about licensure and what we require for licensure, and people just want to get more to the tactical aspects of it. But what are those other areas of practice that we really need to build in? I mean, social innovation models, looking across different disciplines, all those other spaces of opportunity that we have a window right now to really leverage, and we need to do that.
Great, I agree. And I see Christina Madison has her hands up. I'll just sort of mention that at the same time, we know this is ending. There's also shifts to not cover telehealth visits, which, you know, would be sort of the exact opposite of what you might want to do during this kind of transition time. So, you know, we're also confronting policy and other adjustments that aren't necessarily aligned with what we're hoping for. But Christina, do you want to come on and ask your question? I see your hand raised.
Yes, thank you so much. I really appreciate the opportunity to speak. Are you able to hear me?
Yeah,
Yes.
we can hear you.
Fantastic. So first and foremost, I just wanted to say thank you for such an insightful conversation. I think having these spaces and having the ability to talk about these things openly and honestly is just really incredible. And then just looking at the dynamic of the panel also makes me have all the feels because again, I think representation matters. And so having minorities, women, it's very very lovely to see. And so with that being said, I just wanted to also kind of bring it back to like, how do we shepherd the process with utilizing messengers and people that are look and sound like us when we see you know, less and less minorities working in the spaces that individuals that need the care the most are eventually going into, because we aren't seeing funding and money going into those areas. And so my question / comment is, how do we become sort of the Sherpas of healthcare, right? Because we're moving people through this process, but we're also talking about preventative care. But then how do we navigate these spaces where so many of the people that we need to help the most are not seeing people who look and sound like them, taking care of them, and are reflective of the communities that we serve as healthcare professionals?
You know, I would like to answer briefly in these quick 30-second answers. I think what Marianne said is super important. We need to name things. After we name things, we can start doing things. And I think most organizations have formulated offices of diversity, equity, inclusion, or BIPOC, and senior level positions that are sitting at the table, that are making these decisions, that are working on workforce, working on employee benefits, working on well-being, and we've named it and now we're doing it. And I would say that's the first step. That's another thing that came out of the pandemic. I mean, this all started happening around the last 3 years. And it's another one of the benefits that came out of, just a really difficult 3 years.
Great. Thank you. I want to make sure that we have time for, there's a couple folks that have their hands raised. First, we're going to go to Heather Fitzpatrick, and then we're going to go to Ruth Thomas Squans, if I pronounce it right. So Heather, first to you, and try to keep your question brief.
Absolutely. Well, and maybe I'll hold off then. I was responding to the questions that were posed in the chat, and just an exciting thing that we're working with, connecting our members with the Surveillance for Emerging Threats to Mothers and Babies Network. Just a unique kind of thing that's going on with public health and healthcare, and trying to get that data that public health is collecting into the hands of folks who are seeing families directly and kids. And just it's something that I'm excited about, and it's pretty new for us, but would love to hear if there's anything like that folks are working on as well, that we might just sort of learn from.
Panel, anyone want to respond to Heather?
No, I didn't have anything specifically. I know that there is work that's happening specifically, like at IHI, in terms of supporting organizations using data, specifically looking at data, deaggregating data, stratifying data, all of those different ways. But that's something that's happening within action network communities. But I know that there is a lot of work that's happening in that space with much more intentionality specifically.
I would say another thing is the use of mobility data. Anonymized mobility data has been super, super helpful. For example, when state health official, we would put our public health practices in the community where we had offices. It had nothing to do where people could access them. It was just wherever we had a building. Now with Wellness Equity Alliance, we pair SDOH data with mobility anonymized data, and we actually move our practices to where they're at. Sometimes they're in the parking lot of an auto supply store, like in Laredo, which is what we were doing when we were immunizing and vaccinating people and testing. So I think that's kind of what we're seeing now. And I think that's the way we should be. We should be taking healthcare to the people instead of making them come to us. And it's really easy now to get to people. It's unfortunate with what Lauren said about with the emergency rollback, we may not see telehealth access anymore, which some of our older patients loved it because they never have access to drivers and getting onto public transportation. So it's going to be hard.
And can I just add one more thing about the data too, Heather, to your question? I also see a lot of data animation that's happening. And so in terms of bringing data to life, telling stories with data as well, and how that data dissemination looks very different than the traditional ways of disseminating data. So also just wanted to lift that up, as I'm seeing that in other spaces too.
Great. Thank you. And let's see, I lost the person. It was Ruth, I think, who.
Hi. Yes, thank you, Lauren. It was me, but I see that we're kind of out of time. So I was lowering my hand if there was time that you had to close.
It looks like we have 3 minutes. If it's a quick
3
question.
minutes. It was really responding to some of the discussion questions that were were placed in the chat, and this notion of opportunities for valuable collaboration. And I would put to the panel, how do you see, we talk a lot about identifying social determinants of health, we're screening them. Where do we see the role of public health and healthcare in partnering with those that are changing the social determinants of health, the ones that are outside of the clinical delivery system? And how do we incentivize that engagement to sort of incorporate that into the sort of role that we see for as a sort of a real sort of foundational preventative approach?
Thank you, Ruth. So in our quick responses, thinking on your feet here.
I would say part of it is how we in public health and healthcare, when there are like one very specific thing, when there are RFPs or NOFOs issued by government agencies, for example, how might we think creatively about who we're partnering with when those awards name eliminating disparities, addressing social determinants and drivers of health? How can we think creatively about who's generally invited into those funding collaborations in the places where health, well-being, and equity are actually created?
Great. Well, Andrea, it looks like we're coming close to the end. We have 1 minute left, so I'm turning it back to you. I just want to say thank you to the panelists for their incredibly thoughtful responses and the great work that they're doing. So thank you for participating.
I just want to echo that thanks, and especially to Lauren for being such a great moderator for the group. I think we really got to a lot of different issues, and hopefully really raised some good topics within our private circle here. So remember, everybody, it stays in Vegas. But it was great to see everybody. Please let us know if there are things that you'd like to share with our Alliance partners. There are topics you want to bring to future meetings. We really do see this as a place to have these discussions and try to figure out how we can learn and share with each other. So with that, thanks to everybody. Have a great month, and we will talk to you in April. Thanks so much, panelists and everybody else.
Thank you.
Thank
Bye-bye.
you. Great to meet you all, panelists.
Bye.
Bye-bye.